Welcome to this explainer. Look, if you're working on the wards, covering the ED, or pulling a brutal ICU night shift, there is one diagnosis that constantly lurks in the shadows, just waiting for a moment of clinical hesitation. We are talking about pulmonary embolism. This is your critical, high-yield guide to identifying, risk stratifying, and managing PE before the hemodynamic clock runs out. We're going to break down the pathophysiology, navigate those tricky diagnostic traps, and map out the exact treatment algorithms you need to save a life on your very next shift.
To really understand the stakes here, we have to look at the numbers. 600,000. That's how many cases of pulmonary embolism we see every single year in the US alone. Just let that sink in for a second. It's the number 3 cause of preventable hospital deaths. And here's the truly terrifying metric for any clinician. There's a 30% fatality rate if this is left untreated. Literally, 1 in 3 patients will die within a month if we miss the diagnosis. The margin for error is practically zero.
Okay, let's dive right into this clinical arc. We'll be covering patient presentation and risk, the hemodynamic death spiral, navigating the diagnostic minefield, the hemodynamic treatment fork, and finally, racing against the clock.
Starting off with Section 1, Patient Presentation and Risk.
So let's ground this in clinical reality. Meet Priya. She's a 42-year-old software engineer who just presented to your ED with sudden, severe breathlessness at rest, some right-sided chest pain, and this profound sense of impending doom. Also, notice her right leg. It's been swollen for 3 days. What about her risk factors? Well, she's been on oral contraceptives for 3 years, and she just got off a 4-hour long-haul flight about 5 days ago. Now check out her vitals. Her heart rate is screaming at 124 beats per minute. Her blood pressure is 92/60, meaning she is teetering right on the edge of a cliff. She's satting at 88% on room air. Her D-dimer is highly elevated at 3.8, and her troponin is mildly bumped at 0.06. Make no mistake, this is a 5-alarm fire.
What's fascinating is how Priya's history maps so perfectly onto Virchow's Triad. It's honestly kind of wild to think that Rudolf Virchow mapped out this exact architecture of a clot way back in 1856, and it's still dictating our ED protocols today. Priya has 2 massive triggers here. First, hypercoagulation, which is being driven by her OCPUs. Second, venous stasis, just from sitting immobile on that long-haul flight. When stasis meets a hypercoagulable state, a deep vein thrombosis initiates. That clot in her swollen right leg, that was just a ticking time bomb.
Moving into Section 2, the hemodynamic death spiral. That DVT has now embolized.
The progression of a PE is rapid and, frankly, lethal. Let's break it down. Step 1 is the blockage. The clot occludes the pulmonary artery, stopping blood flow, which creates a massive VQ mismatch and rapid hypoxia. Step 2 is the backup. The right ventricle is suddenly forced to pump against a massive afterload, and that leads to rapid RV pressure overload and dilation. Step 3 is the squeeze. As that RV balloons out, it causes a septal shift, bowing directly into the left ventricle. Because of that, left ventricular preload absolutely plummets. And finally, Step 4, the crash. With almost no blood getting to the left side of the heart, cardiac output drops to 0, leading to cardiogenic shock, tissue hypoxia, and ultimately pulseless electrical activity, or a PEA arrest. And to make matters worse, the neurohormonal release of serotonin and thromboxane causes even further pulmonary vasoconstriction. The real disaster happening inside the chest is structural. The right ventricle dilates so massively that it literally crushes the left ventricle. Whenever you hear clinicians talk about an RV to LV ratio greater than 0.9, this is the anatomical reality they're talking about. The left ventricle is entirely starved of blood, which means the brain and the coronaries are starved of blood.
All right, Section 3, navigating the diagnostic minefield. Let's prepare for the traps that could cost Priya her life.
Listen up, medicos, because this is probably your most important heuristic today. We are looking at 5 fatal diagnostic traps. Trap 1, treating a wheeze as asthma or COPD. The clinical reality? Always risk stratify first, because a PE wheeze can totally mimic bronchospasm. Trap 2, relying on a normal D-dimer in high-risk patients. Remember, D-dimer is strictly for ruling out PE in low-risk patients. If they have cancer, are post-op, or pregnant, it's completely useless. Trap 3, waiting for a troponin or an echo to give heparin. This is a fatal mistake. Every single minute equals more clot. You need to start heparin immediately on high clinical suspicion. Trap 4, dismissing an ECG just because it doesn't have an S1Q3T3. That classic pattern actually only shows up in about 20% of cases.
Simple sinus tachycardia with right heart strain is your real red flag. And trap 5, ignoring the legs. Unilateral calf swelling plus shortness of breath is DVT-PE until proven otherwise.
So how do we turn all this into an actionable plan? We use the Wells score to quantify our suspicion. Looking back at Priya, she has clinical signs of a DVT, which gives us plus 3.0. PE is the #1 most likely diagnosis, so that's another plus 3.0. And her heart rate is over 100, which is plus 1.5. Her total score is a whopping 7.5. Look at the pathway here. Anything over 6 is high risk. That means we completely bypass the D-dimer. We go direct to a CTPA, and crucially, we start heparin right now before she even gets to the scanner.
Now, when we actually get the imaging done, CT pulmonary angiography is the gold standard because it provides a definitive filling defect. You literally see a dark void obstructing arterial flow. Conversely, a chest X-ray might show a Hampton's hump. That's a wedge-shaped opacity indicating lung infarction. It's highly specific, sure, but it's incredibly rare. Just remember this clinical heuristic. A completely normal chest X-ray plus unexplained tachycardia and shortness of breath equals a very high suspicion for PE. Do not be falsely reassured just because the lungs look clear.
What about identifying cardiac strain? Okay, yes, on the ECG, you might see the S in lead I, the Q and inverted T in lead 3, the famous S1Q3T3. But like we just talked about, don't hang your hat on it. Look out for the most common finding instead, simple sinus tachycardia. On an echocardiogram, you're looking for the feared D sign. This happens when the right ventricle is so overloaded with pressure that it flattens the intraventricular septum, making the left ventricle look exactly like the letter D. This is a huge red flag that predicts imminent hemodynamic collapse.
Section 4, the hemodynamic treatment fork. We've identified the enemy, now we have to make the call.
So the crucial point here is deciding which path to take. Once PE is confirmed, you face a hemodynamic fork in the road. Is the patient unstable, meaning is their blood pressure less than 90 millimeters of mercury, or are they actively in shock? Or are they stable, with a BP over 90? Priya's BP was 92/60. She is right on the line, but technically she goes down the stable pathway. This means oxygen supplementation and immediate anticoagulation. Now, if she had dipped below 90, we'd be looking at a totally different scenario: vasopressors like norepinephrine and systemic thrombolysis with Alteplase. Let's rapid-fire your anticoagulation arsenal. Unfractionated heparin, or UFH, is your immediate bridge. It's an 80 units per kilo IV bolus, followed by an infusion. It's easily reversible and absolutely perfect for patients teetering on the edge. Low molecular weight heparin like enoxaparin, well, that's your first choice in pregnancy or cancer. DOACs like rivaroxaban are going to be your standard stable outpatient care. And Alteplase? That's your systemic thrombolysis. You're delivering 100 milligrams over 2 hours, and it's strictly reserved for unstable, crashing patients. Oh, and always have protamine and FFP ready for major hemorrhages.
Now, I know textbooks always assume you've got unlimited resources, right? But clinical practice often requires adaptability. Here are some real-world resource hacks derived from the Indian clinical context but applicable pretty much anywhere. Don't have access to a CTPA? Use a high Wells score combined with a lower limb Doppler. If you confirm a DVT in a breathless patient, just treat it as a PE. Are DOACs cost prohibitive for your patient? Use widely available UFH with APT monitoring instead. If the patient has a delayed presentation, get them transferred to a tertiary center early. The point is to adapt to your environment, but never ever delay the anticoagulation.
Finally, Section 5, racing against the clock. Let's see how our rapid interventions played out for Priya.
So here's her successful recovery timeline. At hour 0, her Wells score was 7.5, and a UFA bolus was pushed immediately in the ED before any imaging happened. Honestly, that move likely saved her life. By hour 2, the CTPA confirmed a bilateral saddle embolism, a submassive PE. At hour 3, the echo did show RV dilation in the D sign, but her vitals managed to hold steady. By day 1, she was stable enough to transition to the ward and switch to oral rivaroxaban, permanently stopping her OCPs. Fast forward to week 6, full resolution was achieved, and a further workup actually discovered she had an underlying factor V Leiden mutation, so she's now on rivaroxaban indefinitely.
But let's take a beat and consider what could have happened if we'd missed the diagnosis or hesitated even a little bit on that heparin. The catastrophic complications here are brutal. Cardiac arrest via PEA is the terminal event. She could have suffered a pulmonary infarction, where the lung tissue literally dies and causes hemoptysis. If she happened to have a patent-forming ovale, that clot could have shot directly into her arterial system, causing a massive paradoxical stroke. And even survivors aren't completely out of the woods. 3 to 5% develop CTEPH, or chronic thromboembolic pulmonary hypertension, which leaves them progressively breathless for months or years later.
The absolute biggest takeaway from this entire explainer is urgency. Act before the clot wins. Normal X-rays and normal ECGs do not rule out a pulmonary embolism. You have to calculate the pretest probability. If that Wells score is high, you anticoagulate immediately. Diagnostic delays hand the clot its victory, and that physiological death spiral we talked about, it waits for no one.
We've covered a lot today: the numbers, the physiology, the diagnostic traps, and the treatments. But look, knowledge is only power if it actually changes your behavior at the bedside. Pulmonary embolism wears 1,000 masks. It mimics asthma, it mimics anxiety, and it loves to hide behind perfectly normal imaging. So my final question to you is, how will you change your clinical practice to unmask it on your very next shift? Thank you so much for joining me today. Stay sharp out there and keep saving lives.